Okay, welcome back everyone from our mini break after our excellent top oral abstract session. I'm glad you're rejoining us and hope everyone got a little mini break in there, a little snack, cup of tea. So I'm going to introduce the next session, which is our Mario S. Cooper Memorial Colloquium, titled Hidden HIV Epidemics, Keeping Pace with the Growing Speed and Diversity of Migration. And before I introduce our moderator for this colloquium, I'll just say a few quick words about Mario Cooper. Jorge may want to expand upon it if he likes. But Mario Cooper, important figure in the HIV epidemic. He served as a liaison between politicians, AIDS and gay rights advocates, and civil rights leaders. He was the first African-American and first openly HIV positive board chair of the AIDS Action Council, which is now AIDS United, where he implemented changes to the system of allocating Ryan White funds to do better target communities of color and places where the HIV/AIDS crisis had already taken hold. He's renowned for his relentless work in HIV/AIDS advocacy and is remembered as a national leader in the fight to end HIV/AIDS, particularly in communities of color. So it's why we honor him and every year have this very special colloquium. Okay, so this will be chaired by another leader in the field, Jorge Saavedra, who is the Executive Director of the AIDS Healthcare Foundation Global Public Health Institute at the University of Miami. And he also serves as the acting chair of IAPAC. So I thank you, Jorge, and I turn it over to you now to moderate this panel.
Okay, well, thank you very much for the introduction, Robert. And as Robert mentioned it, I'm also a member of the board of IAPAC and acting chair of the board of IAPAC. So, and I'm based at the University of Miami at the EHF Global Public Health Institute. So this time we are going to have a session, a very interesting session, and very linked to the colloquium that Robert already explained, and it is about migration and diversity. So we have four tremendous good speakers, and I'm going to just briefly introduce them. The first one is Professor Thomas J. Donohoe. He's a professor of family medicine, and he's also the director of the Pacific AIDS Education and Training Center in Los Angeles area. And he's also associate director of the UCLA Center for Health Promotion and Disease Prevention at the David Geffen School of Medicine at the UCLA. Secondly, we have Dr. Liliana Andrade Forero. She's a medical doctor, and she's the country program manager for AHF Colombia. And AHF Colombia was mainly an organization created inside Colombia to deal with the migration of Venezuelans seeking care, HIV care, in other countries, especially in Colombia, and also not just the migrants ones, but also the ones living inside Venezuela that cannot access HIV care inside Venezuela, so they go to the border of Colombia. So she will explain us later what the program consists of. And then we have also a testimony on how HIV affected my job and study opportunities and migration opportunities. And this testimony will be by Iegor Trieshchov. He's a Ukrainian person. He's based in Amsterdam in the Netherlands right now, and he will share his testimony with us. The last one, but not least, of course, is another testimony from Sasha, or Santiago Lozano. He's a person that migrated from Tijuana, Mexico in search of HIV medication to the US, and he will also share his testimony with us. He's Mexican, but now he's a US resident as well, and he's based in Los Angeles, California. So now, in order to use the time properly, I'm going to leave the floor to Thomas Donohoe to share his presentation with us. All the speakers will have initially 5 to 7 minutes to share their presentation, and later we will come back with questions and answers, not just from me as a moderator, but also from the audience in case there are questions from the audience. So I'll leave it to you right now, Tom.
Hi, thank you, Dr. Saavedra. Good morning, everybody. I'm Tom Donohoe. I'm a professor of family medicine at the David Geffen School of Medicine at UCLA. I'm also a member of a group called UMBAS, the U.S.-Mexico Border AIDS Education and Training Center Steering Team, and I'm Associate Director of the UCLA Center for Health Promotion Disease Prevention. Today, I'm going to take the theme of migration and HIV to the continuity of HIV care in the cases of the US-Mexico border, also for people who are returning to Mexico and Central America. So the theme is keeping patients in continuous HIV care as they migrate, or in this case, as they may return to Mexico or Central America. So in my role at the Center for Health Promotion Disease Prevention, I'm glad that today's talk was named after an AIDS activist, because it was really an AIDS activist that got my work in Mexico started. In the early 90s, a physician who had just finished his MPH at the University of Miami, Dr. Octavio Vallejo, who's from Puebla, Mexico, came into our office at UCLA and said, I really want to continue doing HIV work in Mexico, but I'm not finding any opportunities. So Dr. Vallejo joined our faculty, and we started looking for ways we could bring training and education to different Mexican states. This is a map of Mexico where you can see our first 30 trainings that we did. And we actually didn't do any of these with any federal US funds. All of these were with small donations that came from foundations like the Elton John Foundation, the Magic Johnson Foundation, the Elizabeth Taylor Foundation, and they were all small grants, the Ford Foundation, that allowed us to bring US Spanish-speaking experts and providers and case managers and clergy and psychologists to do sort of, and often some of these places, the first HIV trainings. And this is really important because no two countries share people as much as the United States and Mexico. And so there's even this concept of transnationalism. Even if you're not necessarily an immigrant yourself, just the fact that your parents were, say, for example, immigrants from Mexico, sort of changes your perspective around healthcare. And so you can see in this slide that the connection between not just these two countries, but literally between certain states and certain states in the US, certain states or cities in Mexico and certain states in the US. So for example, the state of Puebla, Mexico, sends a lot of people to New York, and specifically around working in restaurants. And so there's these connections between the two countries that are incredibly strong. The US-Mexico border has about 40 to 50 million passenger crossings each year. And those are official crossings, and it has many unofficial crossings as well. And so within Mexico, there's 5 states here. You can see Michoacán, Guerrero, Jalisco, Guanajuato, that are actually known as migrant exporting states, because such a large percentage of the young people in those states go to the United States to work. And so for over 15 years within the AIDS Education and Training Centers, we have on the US side a group that coordinates our efforts. It's called UMBAS, which sounds German, but it's actually the US-Mexico Border AIDS Education and Training Center Steering Team. We're really proud of the work that we've been doing over these past 15 years, coordinating trainings on the US side. And because we train US providers, they always tell us in the needs assessments that we do to please maintain a binational perspective. So for example, if you're working here, hopefully you can see my cursor between Calexico and Mexicali, all those providers on the site in Calexico tell us, please work as much as you can, maintain a binational perspective. And so with those funds from those foundations, we were able to do binational trainings and pull providers over from the Mexican side, and we would have simultaneous interpretation, for example. And then in 2007, we invited Dr. Saavedra to our meeting in Texas, and that was 1 year before the International AIDS Conference was happening in Mexico City. And we asked him, how could we help his efforts in Mexico? Mexico was establishing a national, well, it was already been established, but he was teaching us about the Mexican national AIDS system, or SENCIDA, and the different HIV ambulatory clinics that were in every state in Mexico called CAPACITS. And he said, you could really help us by making sure that Mexicans who are returning to Mexico, often through deportation proceedings, know about the HIV resources before they return to Mexico, because unfortunately they're often showing up at border HIV clinics or within the interior of Mexico, not having the information and showing up late to care there. And so we took that to heart, and we created a bunch of fact sheets. Omar Baños is still the person that helps us put together these fact sheets. He headed a publication then called Impacto Transnacional, so he was very familiar with HIV care in Mexico and Central America. So we developed these fact sheets, and they quickly became some of the most used fact sheets on our websites. And when we were Googling our own group to prepare for another presentation, we found happily that the Human Rights Watch International had named us as an international best practice. You can see they have a publication here that's called Return to Risk, Deportation of HIV Positive Migrants. And within it, they said that initiatives to provide cross-border treatment between the United States and Mexico could serve as an example. So programs such as ours, UMBAS, can serve as a model for how treatment can be coordinated for deportees across borders and should be expanded where feasible. So we took the momentum, and we figured the group that most needed this information were immigration and customs enforcement clinicians. There's over 100 clinicians that work within immigration and customs enforcement. We worked with Congresswoman Roybal Allard's office to help get entry into training ICE clinicians. And you can see here, about 9 years ago, we started doing national webinars to train ICE clinicians about how you connect to care in Mexico. And we created these fact sheets that quickly became some of our top downloads from our border website. And we would get requests immediately. Please develop these fact sheets for Central America. So we did that. We developed them for every Central American country except Belize. We had a hard time getting information for Belize. But we now have both Belize, and because of requests, we also developed a fact sheet for the Dominican Republic. And so this basically tells you how you access HIV care in that country. And so our target are US providers who may have a patient who is considering returning to Mexico, for example, because of retirement, but most likely it's that they've heard that the patient is returning because of legal proceedings or deportation. So if you Google HIV patient returning to Mexico, you'll get a link to all of our fact sheets in English and Spanish. And all of this is really possible because of our previous work, volunteer work in Mexico, learning how the healthcare system there works. And because today, because Mexico has at least one HIV ambulatory clinic in every state, there's 32 states in the Republic of Mexico, there's over 70 of these capacites, which is basically the acronym in Spanish for ambulatory center for HIV care and for sexually transmitted infections as well. So it's really important that, for example, when we do trainings for ICE clinicians, that they also know that if somebody is at risk for a sexually transmitted infection, that's also where they would go to these capacites. So I'm going to turn it back to Dr. Saavedra, who's going to introduce our next presenter.
Yeah, well, thank you very much, Tom. Take it exactly 7 minutes. So I'm encouraged the other speakers also to use properly their time so we can have time for questions and answers at the end. So I will leave it now with Dr. Liliana Andrade Forero. Liliana, the floor is yours.
Hello, good afternoon. I would like to share my screen and my presentation. Hello, I would like to share with you the AHF clinic in Colombia and how it is offering services to Venezuelan migrants crossing the border in order to access to HIV treatment in the Colombian side in times of COVID-19. Based on the latest September Colombian migration report, more than 1,700,000 people are registered as migrants from Venezuela, of which almost 1 million are in an irregular migratory situation, which avoid them to be attended by the Colombian health system. It is evident a growing increase in migrants until the end of 2019, but from February 2020, a reduction in the number of migrants by 5.8% is clear, comparing February with September. This is our comprehensive care clinic for people with HIV, where rapid tests for HIV tests are offered to the entire population, and people who test positive and immigrants in an irregular situation stay with us to receive attention. We also provide care in Bogotá, the capital, Bucaramanga, Arauca, and Casanare. This is the free and high-quality comprehensive care package for irregular migrants with HIV granted by AHF Colombia. Condoms, education for prevention, rapid test for HIV and syphilis, comprehensive care by an interdisciplinary health team, prophylaxis and treatment for opportunistic infections, nutritional support, antiretroviral treatment for pregnant children and non-pregnant patients, diagnosis for these children from mother with HIV, milk formula for these babies, prophylaxis for the first 42 days for these babies, all the clinical laboratories analysis for the beginning of care and the follow-up for all these patients, including CD4 count, viral load, and others if is necessary. And finally, all the strategic information management for the health authorities in a special informatic platform. This is our comprehensive care cascade in AHF Colombia. We have done more than 18,000 people screened for HIV, of which 12% were positive, much more among Venezuelans, it is 20%. 84% remain to be treated with AHF Colombia, of which 81% are retained in care, and 99% are retained in antiretroviral treatment. And finally, 87% have undetectable viral load. The data of positivity in a screened migrant pregnant woman is important. The percentage is 2.6%. This is 6 times more than the positivity among Colombian pregnant women. In this slide, you can see that 50% reduction in mother-to-child transmission of HIV among 2020 have been done. We believe that this can be possible maybe because since April, women cannot return to Venezuela to deliver there, and their births must be attended by the Colombian health system. On the other hand, the HIV positivity in this population have been growing up to 2.6%. The number of people tested and diagnosed as positive fell dramatically in April with the implementation of the confinement for COVID-19, when we had to implement early the strategies to continue serving the population. We observed a high positivity among Venezuelans, this is the red line, and a 4% of positivity among Colombians. 15% of Venezuelans, the red line, did not know their diagnosis in the moment that we offered the test, while almost 100% of Colombians have been diagnosed for the first time. The lowest percentage of retention in antiretroviral treatment that we had is 96%, but we had seen a decrease in a percentage of undetectable viral load up to 87% in the month of September. 96% of our cohort is receiving TLD as combination for antiretroviral treatment, and the remaining 4% receives different combination because toxicity or because they are pediatric patients. We have no therapeutic failure in the 2 years of care. 366 people have been declared inactive. It means with at least 91 days without contact with our attention. It is very important to show that from this quantity of people, 42% leave the cohort because we have managed to affiliate them to the Colombian health system. 37% have actually dropped out, 10% have died, 10% have been transferred to other AHF programs in other countries, and finally 1% have voluntarily left because they want to receive their treatment in Venezuela. The percentage of TB-HIV co-infection remained in 1.5%. Regarding mortality, 35 patients in our cohort have died, which represents the 2.5%. The majority unknown cause because they die in Venezuela, 25% associated with HIV, 14% other causes, and 8.6% related to TB. In this map, you can see where live our patients. The majority live in the Venezuelan side, and the others, 500, live in the Colombian side. These are the adjustments implemented to the care model to quick recovery quality and productivity indicators because COVID-19. We have to offer rapid tests by appointment online, triage risk survey for COVID-19 before appointment scheduling, and pre-HIV test counseling for both online, strict prevention protocols, telehealth for those stable patients with undetectable viral load, sending by post-mail for 3 months medicines, personal protection items for COVID-19, and also condoms, paraclinical follow-up with the laboratories in the city of residence, telephone follow-up of adherence, toxicity, and side effects, and finally, only 60% of our cohort have been attended personally. And these are our quality indicators. 100% start attention after 1 month of the diagnosis. 2 days is the average of initiation of attention from the moment of diagnosis. All the patients have at least 1 CD4 per year, and also viral load, and the 90% of our patients have suppressed viral load in the 2 years of care. I would like to share with you some small video that shows some testimony of our clinic. Thank you very much.
Me llamo Daniel Moreno Astudillo, soy ciudadano venezolano y vengo a HF Cúcuta a recibir mi tratamiento ya que en Venezuela no puedo conseguir tratamiento ni atención médica. Gracias a HF, aún en la pandemia, he podido llegar hasta acá y he podido obtener el tratamiento y mi vida ha cambiado. Hoy en día ya soy indetectable y eso es una esperanza para mí. El equipo de AHF me ha atendido muy bien, están muy atentos y siempre están pendientes, incluso por teléfono, de mis necesidades. Gracias a AHF Colombia recibí mi tratamiento por 3 meses.
Mi nombre es Rafael Anderson Reyes García. Emigré de Venezuela pues, por la situación país. Bueno, en medio del COVID con, digamos que, mucha tensión a raíz de todo lo que está sucediendo, lo que está aconteciendo y tomando las precauciones ante esta pandemia. De verdad que cambió, digamos que un poco a raíz del haberme enterado de lo que tengo como tal y nadie se espera tener algo, digamos que paciente positivo pues. Pero afrontándolo con madurez, con la mejor actitud y bueno, viéndole el visto bueno a las cosas en realidad. Pues la atención ha sido estupenda, demasiado buena, es más, buena queda corto la palabra más al describirlo porque la atención ha sido excelente, súper atentos en todo el sentido de la palabra.
Thank you very much, Dr. Liliana Andrade, for this presentation. And now I'm going to bring our friend Iegor Trieshchov. I don't know but we want to hear from you, your testimony on what happened to you while you were living, you are Ukrainian, you were living in Kiev, and what happened when you were trying to find out opportunities for job and for studying abroad. So I'll leave it to you. You have 7 minutes, and then we will bring back, we'll go back with you with some questions if you can share with us your testimony. Iegor, the floor is yours. You can unmute yourself.
Yeah, super. Thank you, George, and thank you for having me and sharing my story. So, as George said, I'm Ukrainian and I live now in Amsterdam. I moved here 10, 11 years ago. So what happened, I was like very young, 23 years old, and the political situation in Ukraine is kind of unstable. So I decided to move to Dubai to work in the hotel. And as we all know, probably that in Dubai, you need to, before you get your working visa, you need to show the test of HIV and also hepatitis C. So when I went to the doctor, I didn't know that, like, because I was doing the testing, but not very often, because in Ukraine it's also kind of like, yeah, it's still back then, it was kind of not so regularly people doing. And so I went there, I got tested, and in 3 days I received the results that like I'm positive. So basically I couldn't proceed further with my working visa. And at the moment I felt like, you know, a bit like lost, or kind of like, you know, sad, lost in everything in one thing. However, like, because of, I didn't give up, and I left to Israel. Also, like why I left, because also like in Ukraine back then, the medication was quite a problem, and I was very young, like I was 23 or 24 years old. So I decided, okay, it's better I go somewhere else, because it's not really easy to get medication in Ukraine, and a good medication without any, like, a lot of side effects. So I left to Ukraine to Israel, and from Israel I moved to Amsterdam. So the first story, like, you know, the work experience, I was young, Dubai, it's kind of, you know, okay, that's one thing. But then when I started to study in Amsterdam, I studied international business management. And I was chosen to go to Nanyang in Singapore, which is one of the best business school in the world. And when so I was chosen, I was accepted to the school, and then I went to my doctor, because I was like, okay, I'm going to Singapore. I need like for 6 months medication. She said like, oh, okay, like good luck with that, because like Singapore is, you're not allowed to, like, they not accept students who has HIV. I was like, okay, I'm gonna be, because I was scared, like, you know, with all this medication, go to Singapore. I didn't want to be like turned off on the border. So I contacted the school, and I was like, okay, my situation is like this. And they said like, yeah, we need to look at your papers. Can you send us the statement from your general practitioner, from your main doctor, about your CD4 and all this kind of stories? And I did it. However, they sent me like a reply that, I'm sorry, but we cannot host the student with the HIV. For me, it was like kind of upsetting, and in a way, like feeling that like we live still in barbarian times, you know, when people are judged by the status of HIV, which is not supposed to be a case, because maybe 20, 30 years ago, people were scared, people didn't know what it is, and we didn't know how transmitted, it was not curable. Nowadays, like, I feel no difference like with other people, you know, all my friends know that so I don't hide it, I don't scream about it, but I don't hide it. And I believe everyone should be treated equally, you know, despite your HIV status. You know, you're not a killer, you're not like, you know, someone who is rob someone or whatever. You're not you're just a normal person who wants to have a better life, or better study, or better, like, you know, better opportunities to develop yourself. So I found it a little bit unfair. However, that's, you know, everything that happens, it happens for the reason. So in the end, I live in Amsterdam. I finished school in France, which is also very good. So in the end, I have a happy ending story anyway. But I know that a lot of people, they suffer from from all this kind of situation, and especially it's very hard for some people, because it's a big stigma. You know, some people mentally cannot support it, and they cannot like just accept it, all this kind of situation. So I think in it should be like organizations should work on more how we can create this equality and make all the countries which is kind of conservative, make them more progressive, understand that this is not the case anymore. So we are not 20 years ago, we're in 2020, and we are like, yeah, everyone is equal. So yeah.
Yeah, thank you, Igor. I will come back with you with some other questions. And now I will share the floor with Santiago Lozano. Unfortunately, he couldn't connect his camera, but he's joining us by his phone, so he can hear us and we can hear him. So Santiago is originally from Tijuana, Mexico, and he migrated to the US, especially at the end of the 90s when treatment was not available in Mexico. And well, he will share with us his testimony. Santiago?
Yes, hi everyone. Thank you for having me, Doctor. I am honored to be part of this conference. My name is, I was born Santiago Lozano. When I became a US citizen, I changed my name to Sasha. And I am Sasha Lozano now. That has to do with a lot of psychological and things that I went through. Um, Being in the border town, it was really easy for people to come to the United States. Our visa things are very easy. It was very easy back then to get a permit to come up and visit and stuff. Anyways, I met somebody up here, and we became boyfriends. We were together for like 8 years. I am a child. I'm the 16th child of a family of 20 kids, and my mom and dad. And I'm the only one that is gay, not the only one positive. There is a brother that is 1 year older than me who's also positive, and he gets care over here in the United States as well because he has a visiting visa. I so when I was diagnosed back in 1989, it was the end of the world for me because first of all, the stigma in my country is really bad, still really bad right now. That I am open about it, but my brother is not. He's heterosexual. He has a wife and kids, and so for me to come out was very hard. But at the same time, I knew that it was a devastating news back then. Everybody was dying left and right. I call it the first pandemic of our times. Um, it was challenging. I went to Conacida. Conacida is an organization in Mexico that it was the only source that existed back then when I was diagnosed, and their way of giving you treatment was treatment for work. You would have to go and sell chocolates or things to make funds so that they could have money to buy the medications. And the medications were not always available. They will given to you if they were available. If they were not, you will miss your medications. I came down to the states because I had access to come up here and visit. At the time, I had no intention of living up here, but I wanted to because of my condition. I knew that was better for me to be in the United States and get healthcare and get medication, the proper medication. So I came up here and um, I found a lot of help through many organizations like Bienestar and AHF and stuff like that that will provide you with education on how to how to take your medications, how to disclosure your status um, along the ride. And I call it a ride because life is a ride itself with ups and downs and curves. And I was arrested here in the States back in 95. And I was brought to the LA County jail here in the States. I was not legal. The people at the jail would deny my medication and they would not give me my medication. I've been very constant on my medication ever since I started therapy. My doctor, who was my doctor for a long, long time, you probably know him, Dr. Klaus Rick Gunter. He worked at UCLA, and right now I think he's in another hospital. I don't remember the name of it. Kaiser Permanente. Anyways, so they denied my medication, and my ex-boyfriend from many years back he had to call the chief police and tell him that I had a condition, that I had HIV, and that I never been with a really high dose of the virus, and therefore my adherence to the medication was very important, and I needed to get my medication. So it took probably about 10 to 15 days for them to start giving me the medication that I needed. Um, Later after that, I don't know if it's because of me taking medication or me being HIV positive. They released me. I went to court. They released me. They had no way of knowing who I was or why I was there, which I did not believe. I told them to send me to immigration because immigration had the jail system has an immigration tank where they send the people that is going to be deported. So I went in there, and within 15, 20 minutes, they call my name and they say, "You're free to go." It was a shocker for me because I thought I was going to be deported. Everybody there was really with broken dreams and just, they were here to work and stuff, and they were going to be sent back. So anyways, I had those two experiences with not getting my HIV medications. There was one time when I came down with pneumonia, and that gave me a AIDS diagnostic, which doesn't change. So I'm gonna have to live with that for the rest of my life. But right now I am undetectable. I've been undetectable for the last probably 10 years or 15. It's a hard work to be undetectable. Once you have to take your medication, doctor, and mental health support groups. All that is a combination for a person living with HIV to have a successful HIV life, if that is suitable in any way or it make it sound nice in any way. The pandemic of HIV and AIDS is still very strong in the world. There's still new diagnosed people, and there's still people who um, discriminate against us very, very much, including the Department of Immigration Services and stuff like that. And so, anyways, that is my experience with HIV. I would love to. I have always participated in many platforms. Like in Bienestar has a yearly event called Testimonies of Hope, Testimonios de Esperanza, and I've been giving my testimony many times, and not just there, in many other platforms uh, about entrapment because it was entrapment. My arrest was entrapment, and I won my case. I won my case. Therefore I was released. And anyway, so being HIV positive in a foreign country other than the United States, it's really hard. I see it with my brother that he has to come up here for medication. I'm now a citizen here in the States, and I'm able to get all the healthcare that I need. And I do take advantage of that because many people do not have that privilege. So I want to thank Dr. For inviting me to this panel. If you have any questions, you can ask me. And I never right now you cannot see me, but I hope there is a picture of me somewhere in the screen. And I love just to participate and make a change in the world and teach somebody that that yes, this pandemic is here and now we're dealing with the COVID. And I have four siblings already that have died due to the COVID. So that's been very hard on me and my family, but we're standing, and I've been teaching them how to deal with the pandemic because I went through all that when people was dying left and right, and when people was discriminated against because you just because of your diagnosis. But I have carried my flag, and I have always advocated that it's not the end of the world, and we can have a good life if we take care of ourselves. But for that, yes, we do need healthcare, mental care. We need doctor, and we need medication.
Thank you very much, Sasha. We just have 17 minutes left, and I'm told that we are going to move to the separate live questions and answers. Is that correct, Mia, who's helping us on this? I'm not sure how to do this part. Do I need to move something, or should I start with my questions, or shall I open the floor for questions from the audience? So I think I'm going to start with some questions that I have because I don't know how to move to live questions and answers. Okay, so I'm going to start with the first question to Tom. So Tom, when you're working on the border issues and with migrants, and also advising doctors, especially to the ones in the U.S. side, that some of their patients are facing some deportation, but they don't. I mean, they can do nothing against deportation because that's not an issue from the healthcare sector. But what do you advise them in order for treatment if they are going to be deported and they know they are going to be deported in terms of treatment? What will be the best advice for those physicians and nurses or AIDS providers, AIDS care providers to do with their patients that are facing deportation?
Right. So I think is to become familiar with what's available in Mexico. And so that could vary from state to state a little bit by the state's own formulary. And so also the U.S. Immigration and Customs Enforcement clinicians reach out to us and ask us for the latest update. And we've actually brought some of them at border meetings across the border so they can visit the HIV ambulatory clinic on the other side of the border. And so first thing is that some medications are named differently in Mexico. So a brand name could be different than a brand name in the US. So as much as possible, try to use the generic names because those will be the same. And so I think the first thing is to overcome some myths because a lot of US providers have myths. They think there's no treatment in Mexico. They often, that's where their starting point is, they think that treatment is not available. And so to explain that, yes, it may not be, close to where the patient's returning to, but they can access treatment at the CAPA seats, that they will go there much like a Ryan White clinic in the United States, and they will have someone that helps them get enrolled in the site there. And I guess to just make sure that the treatment that they're on in the United States will be available to them, for example, in Mexico. And if not, what are the options available to them in Mexico? It was for a long time, a tripla was how most patients got started, for example, in Mexico. So that was our starting point. But now Stribald is sort of the standard of care. And so, that's it. We give them our fact sheets because sometimes they don't know where their patient is. Their patient is missing. And so they may say, we had one relative call and they think that the person may be detained. And so we've also developed a fact sheet with Immigration and Customs Enforcement. How do you connect to ICE and find out if the patient is indeed there? And like Sasha just presented, a lot of people too return to the United States after time in a detention facility. And so we've also been training the ICE clinicians about how to find a Ryan White clinic that's close to where the person is leaving the ICE facility.
Thank you, Tom. I also have a question for Dr. Forero. Dr. Forero, when a patient from Venezuela comes to receive HIV care and treatment at Cucuta on the Colombian border, but they are not going back to Venezuela, but they are not going to stay in Cucuta, they are not going to stay in Colombia, probably they are just in transit to Peru, but they are HIV positive. So what is the advice you give them if they are not staying in Cucuta or Colombia and they are moving to Peru, but they are, of course, they are not coming back to Venezuela? What is the advice for them in order to access treatment?
Yes, we have been created a route between all the other countries with the AHF offer attention. We try to build a very confident environment with the person, no? Trying to them to tell us what is the plan, how much time do you want to be in Colombia, how much time are going to spend here, and they are very confident. They tell us exactly what they are going to do. We give treatment for 3 months because they are working from the border in Cucuta in the north of Colombia, and they are working till the other border with Ecuador. It can take maybe 6 months working. In Colombia, it's not possible to buy a ticket without documentation document. And there is a lot of migrants that they don't have any document, even Venezuelan document. So they have to work. For these people, we try to connect in the center of the country, in Bogota, try to attend again in the middle of the way, and then to connect to another AHF program in other country. That's what we are doing. It's very common to have contact by WhatsApp with them, trying to follow which is the point geographically where they are, if they have any need or any trouble situation. And it's a lot of patience with this history that I am telling you.
Okay, thank you, Dr. Forero. And now I'm coming back with Igor. Igor, I know that 11 years ago, when you were still in Ukraine, it was really difficult to access treatment, HIV treatment in Ukraine, even after you tested positive. But then it was not even easy to move to the European Union because not all Ukrainians can, Ukraine is not part of the European Union, so it was not easy. So why you moved, I mean, you went to Israel and then you transformed your life because traveling to Israel. And I think why you decided to go to Israel?
Yeah, but I already mentioned that, like, when I knew that about so first of all, I would love to, I wanted to leave Ukraine anyway because of the political circumstances there back in, I don't remember when it was, 2009 or 2010. And the second reason, when I knew, when I got results that I'm HIV positive, I was like kind of in shock, broken, and all this kind of things, because like I was not expecting, first of all, but secondly, I didn't know much about that. Only like you know, scary stories from 90s when I was a kid about all this, that if you got it, you die. So, you know, it was kind of a strange period in my life, and it was like, or you do something or you just give up. So in my case, I was like, okay, I went to the doctors which were in Ukraine, but it seems like so complicated, and all this medication was like, I show people like, yeah, taking medication, but like, you know, it also gives like horrible side effects. So I decided, okay, or I will better, if I'm gonna die, I will better die on the beach. So I took the plane and I flew to Israel. And there was without medication, without anything, just staying till the moment I could go to Amsterdam. And when I flew to Amsterdam, back then they didn't give directly medication. Nowadays they give directly medication. As soon you're positive, they give medication to make you totally undetectable. Back then they were also still like practicing this kind of things when you need to wait till 200 CD4. So I waited for 1 year, I think. And then I started my medication. But obviously, I think even in Ukraine, even now, people still facing this kind of problems. You know, in Europe, I don't feel this problem anymore. Like for me, like I just got my med and that's it, it's normal. But I know that in many countries, it's not normal. You know, like people still suffering and people still don't get medication because, or the government cannot provide it, or, you know, like in Europe, we have a insurance system. So everyone is insured and the insurance pays for everything. So basically you got sick, you got your meds, and everyone is happy. But in countries like developing countries and like in Ukraine, the medication is mostly provided by the government. And when there's like not so much money in the government, basically they're also cutting cost on medication, and people like just or don't get medication or get the worst medication what can be possibly imagined. You know, so I was lucky in the way, but I think, yeah, not so many people were as lucky as I am.
Thank you, Igor. Yes, I'm sure of that. Sasha, do you think what you were facing back in the end of the 90s in Mexico in order to access treatment and then you move to the US. Is it the same thing that is happening right now to probably Central American migrants that are staying in Mexico and they are HIV positives? Do you know about those kinds of stories? Not about Mexicans, but Central Americans, perhaps.
Yes,
Sasha?
go ahead.
Yeah, that's the question.
Okay, yes, I have not heard. I know there was a house in Tijuana, Mexico by the beach, and there were some people that were LGBT on the house, and people around the house, because the stigma in Mexico is still really, really bad. Um, People were complaining, and they were with signs, and they were protesting that why these Central American LGBT positive people were in that house. uh, Organizations like BNStar went over and they gave them um, food and clothing and stuff, but they face really bad challenges. As my brother, who is Mexican, who is married and has 3 kids, he is in Mexico. He doesn't want my family to know that he's positive. He doesn't want anyone to know that he's positive. So he doesn't go to the doctor over there, and he goes to the doctor, and he has a doctor in Mexico. But as far as medication, they don't have the medication that he's getting over here. So it is crucial for many people, whether they're from Central America or whether they're here, people that come in the caravans. Many of them could be, HIV positive, and it's really sad to see how organizations. I don't know if Conacida still exists, but I think it's done by the Seguro Social now because that's where my brother goes. The Seguro Social, I don't trust that for 1 minute. I mean, they back in the days, you will go there with pneumonia or whatever, and they will give you a shot and they'll kill you, and they'll say he died from AIDS. And those were stories that I heard over and over and over back in the days. Nowadays, it's different. My brother goes there, but he doesn't get care there, like as far as medication. He does the labs, and that's about it. Most of the medications he gets them over here. Now with the pandemic and the border closed, I signed for his medication, and I get it and I take it over for him. And nobody searches what I have on my suitcase when I go across. They think it's my medication, and so I've been keeping my brother stable and alive all this time of the pandemic. But yes, it is crucial, and it's just a really sad moment that we are all living.
Yeah,
Like I
yeah,
mentioned before, we lost 4 siblings already due to the COVID.
yeah. That's a terrible situation.
Yeah.
Sasha, thank you for sharing that part. So we have a question from the audience to any of you, one of you maybe, um, anyone. The question is, in your experience, how are considerations for maintaining care through migration different from women living with HIV compared to men? Are they different? I don't know who would like to answer that question. For you need to unmute yourself.
I can share that when we first started doing the trainings in Mexico, like I said, we went to over 20 different states in Mexico. I think one of the most important things we did was establish some of the first support groups for women in some of these states that had lots of migration with the United States, because women often felt extremely isolated, that they were alone. And one of the formats, really good format in Mexico at least, was there's radio programs for women in the morning. And many of them are living at home, working at home, but with their partner in the United States working. And so we did radio programs for them to support things like HIV testing, and if you are positive, to go to the HIV ambulatory clinic, but most importantly, to get support, especially from other women living with HIV. I think that's one of the most important connections you can make to a migrant woman living with HIV, is to connect with other women through support groups, through the clinic, through some of the AIDS service organizations. That's my experience.
Okay, thank you, Tom. So we run out of time now. We are about to close now. I just want to thank you all for sharing your experiences, on providing care or training physicians in care, and also the testimonies by Iegor and Sasha, which are really touching, and it's just a show of a reality facing many countries in the developing world when they are migrating to other countries, not just because of the economic reasons that are quite valid, but also because of the HIV status and the access to treatment. It is different now, but it's sometimes the realities can be really tough for all of you, for all of us, and therefore the efforts in order to provide care to all migrants, irrespective of their HIV status, but especially when they are HIV positive, it makes a lot of public health sense. And it's the benefit of the recipient countries, not just to help people, but also to help their own people. So in order to keep them not just alive, which is a human right and a human value, but also to keep their own population protected against infectious diseases. So thank you very much, Tom, Liliana, Iegor, and Sasha. Again, thank you on behalf of IAPAC.
You're welcome.